community-based cardiovascular prevention programs perhaps might be one of the most important interventions that we do in medicine from a public health perspective. Because what they really do is they take the medicine out of the exam room and bring it to the community where people live, where they work, where they socialize, where they worship. And that makes it more sustainable. That also makes it one of the most important public health lifestyle interventions. Because when you're sitting in the office, you're just talking to one patient at a time. But when you take that medicine out into the community using trusted community messengers, you're really impacting potentially population health, and you're impacting in a way that goes upstream. So you're not waiting for the event to happen, but you're starting to impact lifestyle factors, you're starting to elicit behavioral change, and you're starting to do it in a way where people actually get it from these trusted messengers, so they're more likely to sustain it. So I think these models are incredibly effective as a tool in medicine. And I think what really makes them successful is when they're highly focused, when they target a specific group, and they have a very measurable intervention. And I always like to use the impression that you have to eat an elephant one bite at a time, right? So you can't bite off the whole elephant at the same time. And in the same way, what you want to do is design a model that's bite-sized, that's measurable, sustainable, and very implementable. So a great example is really the Black barbershop hypertension model. You've got your high-risk group, which is Black men with hypertension. You've got your intervention, which is people going into the barbershop and giving, counseling and pharmacologic adjustment of medications, pharmacists doing that. You've got something that's measurable, and then you've got a trusted environment to deliver that message in. So I think that really sets the stage for how we should think about launching this on a national scale. And the Million Hearts Initiative is a good example of how the CDC and others have tried to really launch this nationally. But in my opinion, the way to really scale this model nationally is to first create, one, two, or three metrics. So let's say blood pressure might be a metric, or potentially BMI or weight change could be another easy to measure metric. Then to actually have pilot sites, about 10 or 20 pilot sites, where you really hone the protocol and hone the implementation of the metrics, and then to launch it on a more nationwide or systemic basis, including in rural environments, so that people don't necessarily need a physician, a pharmacist, or a trained healthcare professional, but even community members could implement many of those interventions and lifestyle metrics based on those protocols. So I'm hoping that more people will start to do some of these community-based prevention models, whether it's just on your local community level, it's at your state level, or it's potentially even nationally, because I really do think they have tremendous impact on care. So, we talk about community-based prevention models, and one of the things we spent most of our day doing, most of us, is time at work. So a workplace model, a community prevention model, is one of perhaps the most important things that we can do. And it really behooves employers to think about how to create this particular model. So I think the first step in this model is to actually implement cardiovascular risk screening at the workplace. And this could be something as simple as a blood pressure check, a finger stick cholesterol and glucose, looking at lipoprotein A, looking at biometrics like BMI and weight distribution. These are easy to do, simple things that could be done at least annually, but potentially even every quarter, as part of a workplace thing that all the employees at the workplace do. And then that automatically builds in that screening for cardiovascular disease. So I hope to see more workplaces do that. I think part of this is changing the culture of the workplace so you can actually change behavior. Most of us spend most of our day sitting on a computer for several hours. So if your employer mandated an activity break for 15 minutes every 2 or 3 hours, where everybody had to get up from their desk and go up and down the stairs, or take a walk around the building, or do something else that was a tangible change that every single person at work is doing as part of the culture, I think that would be incredible in terms of making that part of your daily routine, and also making sure that you're taking what we call these micro activity breaks, so that you're not sitting for prolonged periods of time, which we know can increase cardiovascular risk. I think employers can change the environment at work. I mean, I often go to hospitals or, dentist's office or what have you, and you see a vending machine in the corner full of candy and sodas and all kinds of other things that we shouldn't be eating. So we really ought to think about whether it's the cafeteria at work or whether it's the vending machine, whether it's the snack basket or whatever, they have healthy choices like nuts and trail mix and fruit rather than a lot of these ultra processed choices that are much easier sometimes to put into the workplace. And then finally, I think employers are key in really helping their employees get digital tools. And this could be a fun workplace challenge where you have employees competing against each other, or at the end of the month, any employee who does kind of the most number of steps, like we do at the American Heart Association meeting. Whoever got the most steps gets a t-shirt and gets a mug from the American Heart Association. It's a fun little game, a fun way to get people motivated to actually, incorporate many of these healthy lifestyle changes. And we can use digital tools to track who's doing what and really help rank people and help them to stay motivated. One of the most important things my mom tells me is you always want to learn from your mistakes. And so I think in medicine, we have learned from our mistakes. And there's many lessons that we've taken away from sort of failed community prevention programs that perhaps we should think about as we're thinking about designing more programs. I think the first and most important, perhaps the most difficult to tackle, is that the initial excitement or momentum wears down. And so sometimes, you open an initiative and you start it and everybody's really engaged, and then as time goes on, things happen, life gets busy, and the momentum dies down. So really figuring out a way to iterate that initiative to keep it something that people continue to stay excited about, and to keep it something that's incorporating feedback from the community. Because if you launch something in isolation, you don't incorporate any feedback, and then you don't assess how it's performing, it's likely to fail, because people over time, our natural tendency, our behavioral tendencies are to stop doing something that we were doing before if it's not giving us return on our investment. So making sure you design an initiative that is not just exciting on an ongoing basis, not just something that you iterate and change as time goes on, but also something that may have either financial incentives or other incentives tied to it to keep people really engaged, because otherwise it's likely to fail. One of the other things that I've seen is the paternalistic initiatives. They're often top down, and those don't work as well either. So sometimes people say that we're designing a community-based intervention for a community. And that's not even the correct language to use. You should say that we're designing a community-based intervention with the community, because you really want to engage them in the design and implementation of it, because that's one way that, again, you're going to create that excitement and that momentum and sort of make sure that people stick with it. One other thing is to make sure it's not overly complicated. I remember I worked at a hospital once where they had a wellness initiative, and it had you had to do 25 or 30 different things. And that's just too complicated, right? And so you want to make it sort of bite-sized, like I said before. It's just one or two things that somebody has to deliver on, rather than expecting them to do 25 or 30 things, which they're unlikely to do any of them if you make it such a big initiative. And then finally, I think what's really important is to make sure that you meet people where they are. One of the things that we fail to do is to recognize the challenges, what we call these social determinants of health in cardiology, that people have. And we design initiatives that make sense for us, but may not make sense for someone in a different social environment. So as an example, taking walks outside, that may be a reasonable thing to do if you live in a safe neighborhood. But if you're somebody who lives in a dangerous neighborhood or somewhere where it's not safe to walk outside, that's problematic. Making sure that you take walks after dinner or during the day or what have you. Well, what if you have childcare issues and you have a small baby at home? How can you actually take a walk with your child? So not incorporating these kind of social determinants of health, work hours, job shifts, financial limitations, environmental restrictions, childcare. These are all really important when you're thinking about designing that initiative, so that you make sure that you set people up for success. Digital tools are incredible when it comes to cardiovascular prevention, and I have been so thrilled to be practicing in an era where we have just an explosion of digital tools. And I think first and foremost, what they do is they sort of level the playing field, because most people, regardless of their socioeconomic status, they have smartphones now. So if you can pair that with other digital tools like smart watches or apps on the phone or continuous glucose monitors or other tools that you can provide to people, you can really help to eliminate many of those socioeconomic economic barriers and, the disparities that exist in medicine, and really try to level that playing field. But more importantly, digital tools allow us to collect data, analyze it, and implement change on a population level like never before. Even think about how we design clinical trials now. It's so different how we screen patients for trials, how we enroll them, and even how we, do imputed outcomes and statistics in trials. Digital tools have allowed us to analyze data on a population level, to pick up trends, and then to give that feedback back to the person. So I imagine in a perfect world, for cardiovascular risk prevention, everybody would have the digital tools that we're hoping, the blood pressure monitors, the glucose monitors, the smart watches that look for arrhythmias, all of these. And we as physicians could send push notifications to the digital tool. We as physicians could analyze not just individual trends, but population trends, and say, okay, in this neighborhood, people are not getting as much exercise as they should. So perhaps we send them a suggested walking route or a trail close to their house in that neighborhood that they could walk on. Or, similarly for dietary things in this neighborhood, most people seem to be going to eat out at processed food restaurants rather than, shopping for fruits and vegetables. So you set up a farmer's market. So I think digital tools could really help revolutionize of course, the way that we assess population trends, but also the way that we intervene upon and change behavior on a population level. And I just hope that they start to make it out into the community more than they already have. Cardiometabolic disparities are something that we've grappled with for decades. And I really think it's going to require a combined approach with really the policymakers, the physicians in the exam room, and the trusted community members to try to not just eliminate these disparities, but continue to identify which disparities are still persistent in the community. And I think about the most effective messages come to us from many different channels. And so really what I envision is that the public policy is where, the disparities are addressed on a policy level, on a public health level. And then the physician really does their job to implement evidence-based medicine and interventions, as well as education. And then it's that community person that not just identifies what disparities are still persisting out there, but really helps to implement that physician's message out in the community. And so that Black barbershop example is a really good example, because we know that Black men have more resistant hypertension. They have earlier onset hypertension. And we also know that they don't get treated as aggressively as some of their white counterparts. So that's that disparity right there. So if we could create a public policy message talking about how Black hypertension can sometimes present differently and be more aggressive a phenotype of hypertension than others, that's that educational piece. The physician then decides to take that message, personalize it to the patients in front of him, educate the pharmacists and the community members that then take it out into the community and implement that change. So I really think of it sort of like a three-legged stool, where you have, the three pieces all kind of working together, and each one is feeding back to the other. So you're not working in isolation. It's not top down, but it's really sort of a bi-directional arrows pointing at all three parts of that to really implement change. Now, changing public policy is more challenging than it sounds, and it's harder to do. But I do think that if we continue to at least try to identify the disparities, that's the first step in trying to get them resolved and improving, cardiovascular outcomes for many of these populations that have continued to suffer silently for so many decades.